Hello, this is Farah Douglas, President and CEO of the Liver Health Foundation. Thank you for joining us. Liver Health Foundation is a California-based entity. We are a nonprofit 501c3 foundation representing millions of liver patients in California. Our governing body is our board of directors whose members represent liver patients and caregivers. Our guiding light is Liver Health Foundation's Medical Advisory Council. That's chaired by Dr. Sami Saab and has over 37 right now members. The members of our MAC, Medical Advisory Council, are some of the best hepatologists and liver specialists in the United States. Our mission is to provide updated and accurate information on liver health, to promote prevention of liver disease, to advocate for equity in access to healthcare, and to host community and physician-centered educational programs. To register for our upcoming programs and events, please visit our website, liverhealthfoundations.org. Tonight's subject is PFIC, a rare pediatric liver disease that, if left untreated, can cause other life-threatening liver illnesses. We hope tonight's panel of experts bring more clarity and accurate information to you. Tonight's program has been made possible by a grant from Albireo Pharmaceuticals. We thank Albireo for their support of our efforts. I am now happy to introduce Albireo's representative with us tonight, Dr. Danielle Dray, Senior Medical Director, Global Medical Affairs. Dr. Dray is a board-certified obstetrician gynecologist. Since making her transition to the pharma industry, she has worked in various therapeutic areas, including postpartum depression, inflammatory bowel diseases, and others. Danielle is currently a senior medical director within Global Medical Affairs at Albireo with a focus on cholestatic liver diseases. Dr. Dray, thank you so much for joining us. Please give us a little bit more information about Albireo.
Good evening, everyone. Thank you so much for having me. It's lovely to be here. And thank you so much for joining the program. So tonight we'll just be giving a little bit of an introduction on the medicine called Bylvay, also referred to as odevixibat, to treat the itch from progressive familial intrahepatic cholestasis, otherwise known as PFIC, as many of us are familiar with. I'd love to give a few updates on Albireo that some people may have heard about, in the news, in the paper. And so one of them is that as of today, Albireo, the company, was officially acquired by Ipsen, a mid-sized pharmaceutical company. This is very exciting for all of us as it enables us to be very productive, efficient, and collaborate with all of our cross-functional partners within the company to do exactly what we aim to do, and that's to help patients, caregivers, and their families. So we're very excited about that. Additionally, some may have heard, that we recently filed an application with the Food and Drug Administration for another type of cholestatic liver disease called Alagille syndrome, and we should be expecting approval in a few months in mid-June if all goes well. So a few exciting things happening for us right now. So I'd love to delve into Bylvay a little bit more. I'm sorry, I don't have control of the slides due to some technological issues on my end, so I'll be asking for them to be advanced. So if we can go to the next slide, please. Thank you so much. Before we delve in, always important to start with a few disclaimers. As we all know, today's program is sponsored by Albireo, and we are manufacturer of Bylvay, the drug called odevixibat. I'll provide an overview of Bylvay today, and this is really intended for U.S. patients, caregivers, and their families, and patients who have PFIC. This information is truly just for educational purposes only. It's not intended to provide any treatment, diagnosis, or medical advice for any specific patients. You can feel free to refer to the Bylvay full prescribing information for further information about this medicine called Bylvay for the treatment of itch for patients with PFIC, and then always please feel free to contact your healthcare provider for more information about PFIC. We'll go to the next slide, please. Thank you. So let's talk a little bit about Bylvay, which is the first and only FDA-approved medicine for itch in patients who have PFIC. Next slide, please. Thank you. So we've mentioned the medication. So what is it exactly? As mentioned, it is approved by the FDA, and it's prescribed by a healthcare provider to treat patients who have PFIC, and specifically to treat the itch in patients who are 3 months of age and older. This medicine is taken once every day in the morning by mouth and with a meal. Of note, any type of PFIC diagnosis is eligible for this medication. So patients with any type of PFIC can take this. Of note, though, this medication may not be effective in patients with PFIC type 2 with a specific variant. It's ABCB11 variants that's resulting in a non-functional or complete absence of BSEP3, absence of the bile salt export pump protein. Next slide, please. Thank you. So Bylvay has been studied in the largest clinical trial program of patients with PFIC, and I'd like to delve into the study a little bit more so we can understand the data, the results, as well as the safety data. Next slide, please. Thank you. So here's some information about the clinical study on Bylvay. So it included patients who had the diagnosis of PFIC, who are at least 6 months of age. Almost all patients, so about 95% of patients, had significant itch at the start of the trial. This study evaluated 2 doses of Bylvay as well as a control group, or what might be called a placebo group. Patients took medication daily with a meal, as I said, for 6 months total. And the study looked at itch scores and as well as the side effects of the treatment. This study has been completed, and there's now a long-term study that's currently ongoing. Next slide, please. So this clinical study used a specific scale, a scratch scale, to measure how Bylvay was affecting patients' itching. And this scale was completed 2 times per day by a caregiver to report the level of scratching by the patient in the study. If we look at the scale on the left, you can see that this scale was completed twice a day, as I said, morning and evening, asking really how bad was the child's worst scratching since either they woke up or went to bed the night before. You can see the scale ranges from 0 to 4 here. 0, the smiley face, the no itching, no scratching, and that's extending to 4, which is really the worst itching there is. And these scratch scores were used to determine the effect of Bylvay on itch. Next slide, please. So what we found was that patients treated with Bylvay in this study showed improvements in itch. So many patients had improvements in scratching after 4 weeks, and many patients eventually had little or no scratching at all. And of note, most patients had improvement in their worst scratching throughout the study. Next slide, please. So now that we've reviewed the results, I'd just like to take a few moments to review the safety information, because that's very important too. We can go to the next slide, please. Thank you. So some of the safety highlights include that in this study, about 83% of patients treated with Bylvay and about 85% of patients treated with placebo, or the control, had side effects. And there were some side effects that were commonly seen in the study, and those included diarrhea, changes in liver tests, vomiting, stomach pain, and problems with absorbing fat-soluble vitamins. And those specifically are vitamins A, D, E, and K. If we can advance, please. Thank you. So here's some important information to be aware of if you or your child are prescribed Bylvay. I won't read this all to you, but I'll give you a few moments, and then I'd just like to highlight some really important points that I want to make sure we touch upon. So I'll give you a few moments now. So I know there's a lot of text on this slide, but I'd like to just highlight a few points that I think are important to make sure we touch upon. So one is that if you or your child are prescribed Bylvay, you should certainly speak with a healthcare provider if there's abdominal pain, vomiting, diarrhea, or dehydration, as these have been reported with the use of Bylvay. Also, a healthcare provider should be contacted if there's new or worsening diarrhea or dehydration. Some other things that have been seen with the use of Bylvay include increases in the amounts of some liver enzymes, including AST and ALT, and also total bilirubin. Your healthcare provider will run some liver tests prior to treatment and during treatment, but certainly any symptoms of liver problems, as listed here on the left at the bottom of the slide, should be reported to a healthcare provider. Next slide, please. And so I'd like to close this section just with a little bit of a summary here. As mentioned prior in the introduction, we know PFIC is a rare liver disease that often causes itchy skin. Bylvay is the first and only medicine that's approved for itch in patients with PFIC. It's taken by mouth once per day, and that's with a meal. And we saw that in the clinical study that we reviewed, patients with PFIC who were treated with Bylvay showed a decrease in their itching. The most common side effects, as we talked about, that were seen in the clinical study were, again, diarrhea, liver test changes, vomiting, stomach pain, and problems with absorbing those fat-soluble vitamins. And please, we encourage you to speak to your healthcare provider if you have any questions about PFIC or any questions about Bylvay. Next slide, please. So I'm happy to take questions now. I have a few more slides to discuss a patient support program. So if anyone is thinking of questions, I can move on to the next few slides, or happy to entertain questions now.
Okay, I guess there is no question.
Okay, if you don't mind if we advance to the next few slides on the patient support program, and then I can wrap up. Thank you. Great. So I just wanted to touch upon the Albreo Assist program. And this is really a patient support program to help those have access to Bylvay once the healthcare provider has written their prescription. If we can go to the next slide, please. Thank you. And this program was really born out of the fact that we know navigating the healthcare system can be very challenging and very confusing. And Albreo, now Ipsen, are very committed to helping patients on their journey once they have their prescription to Bylvay. So Albreo Assist consists of a variety of personalized support services to help patients and their families navigate their Bylvay journey. If we go to the next slide, please, I'd like to delve into some of more of those details. So what does this patient support program mean exactly? So first of all, once a patient has a prescription for Bylvay from their healthcare provider, Albreo Assist is able to assign a care coordinator to the patient and their family to help them live kind of navigate the way. And that means understanding their insurance coverage, understanding any financial assistance programs, helping patient and their families connect to the specialty pharmacy that's kind of based on their insurance, and that includes getting refills on time. And then equally as important is that Albreo Assist can offer a lot of educational materials and programs to support not only patients, but their family and caregivers, because we know that is very, very vital. So these are resources to help patients and caregivers understand PFIC, as well as providing information on support groups, community resources, patient meetings. And so there's information at the bottom you can see to get started with calling a care coordinator at Albreo. There's also an email address. And if we advance to the next slide, please, that's just offering the opportunity once more for any questions. And a big thank you so much for your time.
Thank you, Dr. Gray. I really appreciate Albreo's support of our activities. Albreo has been a very good partner for Liver Health Foundation. Thank you so much.
Thank you.
It is now my pleasure to introduce Dr. Amrita Narang, who has generously accepted to be the presenter for tonight's program. Dr. Narang is the Associate Professor of Pediatrics, Division of Pediatric Gastroenterology, Hepatology, and Nutrition at the Stanford School of Medicine, Lucille Packard Children's Hospital. She received Master of Public Health from University of Southern California, USC, Doctor of Medicine from New York Medical College, and Bachelor of Science and Bachelor of Arts from University of Illinois, Chicago. She then continued her pediatric residency at Baylor College of Medicine, Texas Children's Hospital, and her pediatric gastroenterology fellowship and pediatric advanced transplant hepatology at Children's Hospital, Los Angeles, CHLA. Dr. Narang has received many awards and honors as an excellent leader, physician, and investigator. She has published many peer-reviewed journal articles, book chapters, and poster presentations. Dr. Narang is a sought-after expert in pediatric liver diseases. Dr. Narang, thank you so much for your support and participation, and we are ready for you to start your program. Is Dr. Narang inside? I know there was a problem. Oh, we see you, Dr. Narang. You're fine.
Okay, thank you. Thank you, Farah, for the very kind introduction. As Farah said, my name is Amrita Narang. I'm a hepatologist here at Stanford, and my main area of focus is cholestatic liver diseases in infants. I'm very grateful to be invited to give this talk today. Here are the things that I will touch upon during my talk today. We'll talk about what is PFIC, the basics, what is bile, how is it made, how and when does PFIC present, and definitely talk about the different types of PFIC. How do we diagnose and manage PFIC? So the definition, PFIC is a group of rare disorders that results from defects in the process of bile formation. It is a very rare disorder. The estimated incidence is about 1 in 50,000 to 1 in 100,000 births. So let's break down the names. So progressive, it can worsen over time. It is familial. It was originally described in families and related to changes in genes. Intrahepatic, which means that it involves, it's a disease within the liver. And then cholestasis, which means that there is poor bile flow and that the bile builds up in the liver. Okay, so back to the basics again. So this is the liver. The liver makes bile, which is a yellow-green fluid, and it flows through these bile ducts. So the three branches are the intrahepatic bile ducts, which then coalesce together to form the main extrahepatic biliary duct, and then it ultimately drains bile into the intestines. The bile is very important to us. The main functions of bile are that it helps absorb the fats in our food, especially the long-chain fatty acids and the fat-soluble vitamins, which are A, E, D, and K. It also helps eliminate toxins from our bodies, such as medications and heavy metals. The bile is essentially water, so 95% of bile is water, and then 5% of it is solutes. Of the solutes, primarily, it is made up of bile salts. So now let's talk about what are bile salts. Bile salts are made in the liver from cholesterol. The red dots here are the bile salts. They are made in the liver cells, which are basically the orange cells, and then they have to move through the liver into the bile ducts, and they do that via these channels, different channels or transporter proteins. For example, this BSEP protein, MRP2. These transporters are abnormal in PFIC. There are a variety of these transporters, and a defect in any of these can lead to PFIC. So PFIC is not a problem in the structure of the bile ducts or how the tubes are formed, but it's essentially in the transporter proteins. Because there are a lot of different types of transporters, there are a lot of different types of PFIC. So for example, in PFIC type 2, we have this transporter that is affected. In PFIC 1, it's a different transporter. For each of the types of PFIC, there is a protein, and then there is a corresponding gene that has abnormality that led to that protein being formed improperly. Although these diseases can have overlapping symptoms, they are all unique and differ in their prognosis. The proteins all have in common that they're all related to making the bile, and deficiencies in these proteins leads bile to build up in the liver, causing cholestasis. So going into detail, there are lots and lots of different types of PFICs that have now been found. Initially, all the original articles, all the original data that you would look at will show you that there's PFIC 1, PFIC 2, and PFIC 3. However, over the past few years, we've learned that there are more PFIC types that have been discovered, and more that are still being discovered as our technology and ability to do genetic tests is getting better. Okay, so are these bile acid transporters just located in the liver, or they're elsewhere as well? As you can see in this picture, some of the bile acid transporters are located in other organs as well, such as kidney, small and the large intestine. They are also located in pancreas. They're also located and associated with hearing. So having PFIC doesn't mean that it's just liver disease. Some of the PFIC diseases or subtypes can lead to damage in other organs as well. How does PFIC present? The presentation, just like the big umbrella term, it's a very variable presentation. The most common symptom in most of PFIC is itching. The itching is out of proportion to the amount of jaundice. One of the reasons the itching happens is because as the bile salts don't flow well through the liver, they get backed up in the liver, they get backed up in the blood, and they also get deposited in the skin. As the bile salts get deposited in the skin, they irritate the skin and cause itching. There can be poor weight gain or growth failure. There can be jaundice, but it doesn't have to be that every patient with PFIC will have visible jaundice. So jaundice meaning yellowing of the eyes or the skin. Some of the patients may have some pale stools or ecolic stools. Most patients will have vitamin deficiencies. As I touched upon earlier, bile is necessary to be able to absorb the fats and the fat-soluble vitamins. If we don't have bile, if the bile doesn't flow properly into the intestines, our body is unable to break down the food and absorb the necessary things from there, such as fat, which is necessary for weight gain, and then vitamins, the A, E, and D, and K. Because the bile doesn't flow well and it can get stuck in the gallbladder, some of the patients can also have gallstones. Most patients will have elevated liver enzymes. Some patients, because of the variable presentation of the different subtypes of PFIC, some patients may only present with end-stage liver disease or cirrhosis or complications of chronic liver disease. As I said earlier, that the transporters some of the transporters may be in different organs, such as the intestines. So some patients may have diarrhea or pancreatitis or hearing loss. And some may also have abnormal sweat chloride or abnormal sweat electrolytes. How is PFIC diagnosed? A lot of testing can be done, but essentially the gold standard for diagnosing PFIC is genetic testing, which often can take a few weeks to come back. So it can be a little bit frustrating and challenging for families who have a cholestatic baby and are going through the process of diagnostic testing. So most oftenly, we do blood tests, including liver function tests. We can check the level of the bile salts or bile acids in the blood as well as in the urine. The genetic testing, which is usually blood testing, It most often is done, it's obviously done in the patient, but sometimes also requires testing to be done in the parents. Imaging tests are primarily to rule out other liver diseases. As I said, it's not a problem with the bile duct, so we often don't see anything abnormal, except for maybe gallstones. We don't see anything abnormal on imaging tests. Liver biopsy can be helpful, primarily to rule out other causes and also to sort of understand the extent of liver damage. This is a very busy slide, but hopefully it will kind of help with differentiating the different subtypes of PFIC. So PFIC 1 versus 2 versus 3. These were the ones that we have diagnosed and have the most sort of data and knowledge about. As you can see, most of the things are very variable. PFIC 1 is most commonly diagnosed in infancy, versus PFIC 3 can be later on in life, even in early adulthood. PFIC 2 is the one that is earliest to present in the neonatal period. Of these, PFIC 2 has the most severe disease course and is most likely to progress at a very rapid rate, leading to end-stage liver disease in the first few years of life. PFIC 1 is a little bit less, the course is a little bit slower, versus PFIC 3 is the least slow of all of these. Similarly, for itching, PFIC 2 has the most severe amount of itching, and then for PFIC 1, and then less likely to be in PFIC 3. As we said earlier, PFIC 1, this specific transporter is present in multiple different organs, such as the pancreas, the intestines, and that's why there are a lot of other organs that are affected as well in PFIC 1. These patients can have pancreatitis, they can have diarrhea, they can have hearing loss, they can have some kidney problems as well. The other two, PFIC 2 and 3, usually do not have other organs affected. The risk of HCC, which is risk of cancer developing in the liver, is the highest in PFIC 2, and that's why usually we would start screening for cancer, for liver cancer in these patients after 1 year of age. The risk of gallstones is also increased in both PFIC 2 and 3. Usually the treatment is fairly similar. Ursodiol, which is actually a secondary bile salt, which is from bears, is used. The benefit of using this is because this thins out the bile or makes it less viscous. And the thought process is that it will help allow the bile that is being formed and is being secreted into the bile ducts to flow easier and cause less cholestasis or less problems with the bile flow. We'll talk a little bit about partial biliary external diversion in the next few slides, and then liver transplantation. So looking at PFIC 4 and 5 and 6, we have less data for these subtypes of PFIC, and so you will see some of the columns are blank. But what we do know is that, again, everything is variable. Usually PFIC 5 and 6 we'll see in early infancy. However, PFIC 4 can be seen later in life as well. PFIC 5 is fairly rapid in progression and rapidly would get to end-stage liver disease. However, for PFIC 4 and 6, they're a little bit slower. There is itching in essentially all of those, but more severe in PFIC 4. In PFIC 4, there have been some case reports of extrahepatic manifestations. However, we're not 100% certain about the full extent of them. PFIC 6 can come with a diarrheal disease, so they can have diarrhea very early on in life, and they can also have a disease called microvillus inclusion disease. If patients with PFIC 6 have worse diarrhea, then they usually have a less severe liver disease. And then the risk of HCC or cancer is highest in PFIC 4 compared to PFIC 5 and 6. Usually in terms of treatment, PFIC 5 often goes to transplant fairly quickly. There have been case reports of improvements with ursodiol and PFIC-4. However, there have been case reports of patients requiring liver transplants as well. In PFIC-6, since there is a lot of small bowel disease or small intestine disease, patients may need a combined liver and intestine transplant. So we've talked a lot about differences between PFIC-4, 1, 2, 3, 4, 5, and 6. However, essentially the main medical management is essentially the same. Since all these patients have liver disease, they most commonly require increased calories. Anyone that has liver disease requires about 125 to 140% of the recommended dietary allowance. This is done by also adding increased protein. So their protein intake should be about 2 to 3 grams per kilogram. We talked a lot about how bile is necessary for absorbing fats. However, there are a special type of fats called medium chain triglycerides, or MCT. So you may have your doctors provide you special formula which is high in MCT, or add MCT oil or liquids into the foods that you're giving. Because these children also have issues with absorbing the fat-soluble vitamins, it's important that we give them additional supplements of fat-soluble vitamins, as well as check those on a regular basis. I've heard from a lot of families that the DECA that we give stains almost everything, and most patients don't like it. The next thing that we've really got to do, which is really the bane of existence of most patients with PFIC, is the itching. And Dr. Dre talked a lot about the new medications that are there for itching as well, which are hopefully going to be extremely helpful. But a good skincare routine and ursodiol used to be sort of the first line treatments, and now we're using the IBAT inhibitors as well. Other medications that have been used in the past with variable success is cholestyramine, rifampicin, naltrexone, sertraline, or Benadryl. It's really difficult to assess itching in babies. It can be very difficult, and most of these diseases, that's sort of the primary indicator, and sometimes that is the reason why PFIC is not diagnosed till much later, because it's hard to sort of know what's going on. But things that manifest as itching in babies is fussiness, poor sleep. They try to rub their faces. In older children, the itching can be so bad that it does interfere with their sleep, with their normal activities, schoolwork, and can definitely affect their learning. And the last thing in terms of medical management would be, most of these patients will kind of, as we saw, continue to progress, and their liver disease will get to a point where they have complications of liver disease, such as ascites, bleeding, encephalopathy, and then we would look for these complications as well as manage these complications depending on which ones arise. Do we have, besides medical management, so if we've tried all kinds of medications for their itching, and we're unable to treat or improve itching for patients, then the next step is surgical management. The goal is to decrease the level of bile salts in the body, and somehow take them out. So biliary diversion is a process where we can remove the bile that is coming out into the intestines. The oldest form used to be nasobiliary drainage, where essentially you put a tube down the nose, this green line, follow it through down to the stomach, all the way up to the liver, and then suck out the bile, and from the intestines, take out the bile, so that way there's less bile that is being absorbed. As the bile flows from the liver into the intestines, 90% of the bile gets reabsorbed in the small intestine here at the ileum. So if we ensure that the bile does not get to the ileum, then it won't be reabsorbed and we can take it out. There are other ways of doing this. The gallbladder is sort of this reservoir of bile in our bodies. So there is partial external biliary drainage, which means that we can put laparoscopically, we could put a G tube or a tube or make a connection directly into that gallbladder and then drain out the bile. This has been successfully used in patients with both PFIC 1 and 2 when itching cannot be managed with medications. However, it's important to note that of the patients, if we looked at patients and seen sort of, how many of them respond with the partial external biliary drainage, then it's important that they haven't gotten to a point of cirrhosis. So if patients do not have cirrhosis and their itching cannot be managed with medications, then these partial biliary drainage is the way to go. So external biliary drainage is when there's something on the skin, on the body, where you can drain it out. There is, most patients don't like having something on their body. And so we have tried partial internal biliary drainage, where you bypass this ileum. So you form a connection between the gallbladder directly into the colon, so that the bile can drain out into the colon and come out of the poop. In the past, people have also tried ileal bypass, which is just connect the small intestine, just bypass this small ileum here, this small patch, and connect the small intestine to the colon over here. However, our small intestine is very, very smart and adapts to it. And so it still it works for a couple of years, but then things kind of revert back to where they are. So partial biliary drainage is a good form of treatment for patients who itching cannot be controlled by medications, and they haven't gotten to a point of liver cirrhosis. If patients have gotten to a point of liver cirrhosis, or the partial biliary drainage is not working, then the next step really would be transplantation. So liver transplantation is considered in patients who have end-stage liver disease or have progressed to a point of having cancer in their liver, and then the liver needs to come out, or have refractory itching. Liver transplantation is good. Is good, and it definitely works. However, there needs to be a lot of conversations with the family and the doctor to sort of make sure that this is the right next step. The response to transplant depends on the type of PFIC that the patient has, as well as the severity of the mutation and the disease. The reason why this is important is for example, for patients with PFIC 1, the defective transporter is in the liver, is in the pancreas, is in the intestines. We can fix the liver and sort of put in a new liver. However, because there is now proper bile flow through the intestine, it actually makes their other symptoms like diarrhea worse potentially after transplant. So something that needs to be considered. With a new liver, they can also have fatty liver occur in the transplanted liver. In some cases, also, the disease could recur in the transplanted liver. So that's why this is sort of a thing that needs to be done with caution. That's all I have from a management standpoint. So now that we know how to take care of these children better, we're also doing more research into sort of how PFIC affects the life of patients. There was one small study that was done to look at whether inherited liver disease affects the IQ in children. They looked at patients with Alagille's, alpha-1 antitrypsin deficiency, and PFIC, and noted that, and did IQ testing and noted that PFIC does not affect the IQ in children, whereas it can in some other liver conditions, but not with PFIC. There's another study recently that was done to look at quality of life in children with PFIC. This specifically looked at 32 children and used a survey to measure their health-related quality of life. And this was done in children who had partial external biliary diversion or children with a liver transplant. So this was not looking at children who had not received surgery or were only on medical management. This showed that both groups, so PFIC with liver transplant or PFIC with external biliary diversion, had similar quality of life scores as compared to healthy children. The black bars are the ones with liver transplant, The middle light gray bars are the ones with partial external biliary diversion, and then the dark gray ones are with are the healthy population. They looked at physical, psychosocial scores for the children, and then also at parent proxy for, so parent responses for the children, and they were similar. As you can imagine that, you know, taking care of a child with a chronic liver disease can be very taxing. This was a recent study that was done to assess, it was the picture study that was done to assess the quality of life of caregivers for children with PFIC. And they looked at information from caregivers of patients with PFIC 1 or 2 in Germany, the UK, and the United States over a period of 6 months. And they received responses from 22 caregivers. Most caregivers reported fulfillment in their caregiving responsibilities, but it definitely led to problems with mental and physical health, finances, and relationships. It also affected, it also had a negative impact on sleep, specifically more so in the PFIC2 subtype of PFIC as compared to the PFIC1 subgroup. Thank you so much for the invitation to speak today by the Liver Health Foundation. I know this was a very, very broad topic, and I tried to touch upon most of it. So thank you for your time and attention.
Thank you so much, Dr. Narang. I really appreciate it. It was a brilliant presentation. Thank you. Now we are going to start the second part of our program. As I mentioned, we have changed the format of this program. So in this part, we are going to have a round table discussion. So you already met Dr. Narang. Thank you. Now I'm going to introduce to you Dr. Robert Gish, who is not a stranger to our audience. He is very helpful to us and attends our webinars and hosts and speaks as well. Dr. Robert Gish is adjunct professor of medicine at the University of Nevada, the School of Medicine in Las Vegas and Reno. He's adjunct professor of pharmacy at the SCAC's School of Pharmacy and Pharmaceutical Sciences at UCSD, a clinical professor of medicine at Loma Linda University, a staff physician at Loma Linda University's Liver Transplant Clinic in Las Vegas, medical director of the Asian Pacific Health Foundation in San Diego, and Hepatitis B Foundation in Doylestown, Pennsylvania. After attending pharmacy school at the University of Kansas, Dr. Gish obtained his medical degree from the University of Kansas Medical School in Kansas City. Subsequently, he completed a 3-year internal medicine residency at the University of California, San Diego, UCSD, and a 4-year gastroenterology and hepatology fellowship at the University of California, Los Angeles, UCLA, which included transplant medicine. Dr. Gish is a fellow of the American Association for the Study of Liver Disease, AASLD, the American Society of Transplantation, and the American College of Physicians. He has served on the editorial boards of American Journal of Gastroenterology, Hepatology, Journal of Hepatology, Digestive Diseases and Sciences, and Gastroenterology. He has co-authored a public health policy for liver health in Vietnam, focusing on HBV, which is hepatitis B, and is also assisting with the development of viral hepatitis healthcare policies in Georgia, Armenia, and the Philippines. Dr. Gish is a well-respected and well-known as a major early contributor in deciphering methods for the detection of hepatitis B and C virus and characterizing the epidemiology and clinical presentation in humans. He was involved in studies that led to the genotypic classification strategies and methods now is used in worldwide. He has published more than 700 original articles, review articles, abstracts, and book chapters. Welcome, Dr. Gish. Thank you so much for your participation.
Glad to be here, Sarah.
Thank you so much. We always love to have you. Our other panelist is Dr. Nasreen Sufi, who is the attending physician, assistant professor of clinical pediatrics, Keck School of Medicine, USC, Gastroenterology, Hepatology, and Nutrition Division. Dr. Sufi completed her residency at St. Louis Children's Hospital and at Washington University Medical Center. She continued her fellowship at the University of California, San Francisco in pediatric transplant hepatology. Dr. Sufi, welcome to PFIC webinar. I will introduce our guest patient representative and then Dr. Gish will start the roundtable. We are very excited to welcome back Ms. Susan DeAngelis. We met Susan last year in a PFIC webinar where she shared her story. Since then, we have received many questions about her. Our liver patients wanted to know how she and her children are doing. Susan has 3 daughters. 2 of them are living with PFIC 4. Sylvie is almost 5, and Genevieve, I believe, is about maybe a year and a half. When we heard about Genevieve, she was only 3 months old and was just diagnosed with PFIC. We will hear about the children as Susan participates in this roundtable. Susan, thank you and welcome to the webinar, and thank you for accepting our invitation.
Thank you for having me.
Oh, thank you, Susan. Dr. Gish, let me start the roundtable by asking Susan to give us an update on her children, since people are really interested in knowing how she's doing. Susan?
Hi. My 2 girls that are living with PFIC are doing great. They're flourishing. I was a dancer myself, and Sylvie, my 5-year-old, is following in my footsteps. She's been doing dance competitions all this year, and she's just doing awesome. And my 1-year-old Genevieve, she is doing great as well, outwardly, inwardly, you know, so with blood work, but she's just a dream and she's so sweet and we're so blessed to have them.
Thank you so much, Susan, for that. Those great comments and positive messaging. Sometimes you look at slides and data and it sounds fairly depressing if we're just going down the route of surgery and transplant. So we like your smile and we're glad that your girls are doing well and benefiting from all these interventions. We got great support now, and pediatric hepatology is just such a fantastic specialty that supports patients preventing transplant or leading to transplant and getting transplant and care afterwards. So we're going to now share questions, and we'll be bringing you in, Susan, into some of these as well, as we're going to ask you some itch questions probably in a minute. But I was going to go back to Dr. Sufi first and also Dr. Narang about itching, because the itch story isn't just bile acids. There's a whole story about autotaxins and lysophosphatidic acid. And why does treating bile acids work in some people and not in others? There's also issues in adults with PBC, PSC, other cholestatic illnesses. And it's basically I have 14 different drugs I use for itching, and depends on which patient and which one works. Why the heterogeneity, and is it just bile acids in kids? Desireen, you want to go first?
Very, very easy question to answer. Not. It's very complicated, as you have outlined, whether it's so in PFIC, for example, type 2, which is the most common, PFIC 2 is the most common type of PFIC. We saw, for example, the studies, that were done for the IBAT inhibitors. It depends on the genetic mutation that you have. You're going to have a different response for that particular medication. Why? Because those medications work in a certain way that affects the bile acids in the intestine, If you have no protein, no B-cell protein, then that medicine is not going to work because you just don't have any bile acids in the intestine for it to work on. So every medicine has a particular etiology. Every patient has a particular mutation. Some of the medicine just has side effects that are really hard for patients to tolerate. Cholestyramine is one of those medicines that could make sense, but a lot of people just don't want to take it. It's just very unpleasant to be on, plus the medication interactions and things like that. So yeah, it's a very complex issue. And yeah, I agree. Some patients it works, certain things work, and some patients it doesn't. So, but there's a lot of promise. I think things are changing a lot with the IBAT inhibitors. Like, there's more hope, and it's beyond just itching. The studies are showing that even the disease progression, the liver injury, the chance of them needing transplant, a lot of this is showing they're growing. So it's very exciting and a big change, during our careers. So hopefully with science and with research, we're learning more. We can do better.
Have you or Amrita ever used primrose oil for itching for your patients?
I have not, but tell us more if you've used it.
That's my first line in every patient, actually, is starting with primrose oil. It does something to modify these fatty acid metabolism. I don't know what effect it has on bile acids, but I'm going to say 60% of people have a nice reduction. Then I can add some other antihistamines. And I agree with you. Bile salt binding resins are loved in Europe. It's first line in all the itch protocols over there. In the US, it's pretty far down the list. We usually start with antihistamines and some other creative options, including naltrexone or rifampicin. And now I'm starting with SSRIs because it helps with energy, and sometimes it helps with sleep, because there's this, as you talked about, a disrupted sleep cycle in these patients, which makes life worse for everybody. Another question, maybe Amrita, you could talk about genetics. Do you need like insurance approval? Is this a big wait time? Do you have to wait a month for the insurance company to review everything, or is it pretty easy to get genetic testing done and paid for?
Yeah, thankfully, I think it's easier in patients who truly have elevated bilirubins. I think it's a little bit easier in pediatrics. There are some cholestasis panels that we can do. Sometimes they are helpful in coming up with some answers. Most often, though, they are what we call them VUSs, which are variants of unknown significance. There is some sort of genetic abnormality, but is not actually causing issues or disease. So I think those genetic cholestasis panels were easier able to get. However, as I was mentioning, it does take about 3 to 4 weeks really for us to get results. And that is a long wait time of unknown, right? Like, what do we do? We don't have an answer, so it takes a long time. But then if we're talking about that wasn't helpful, then talking about doing whole exome, that can take a long time, lots of approvals and getting those done. But I think this is where we're headed, though, is the personalized medicine, as you both mentioned. If we can figure out this is the gene, this is the problem, this is what we got to do. That is some of the battle, but the other issue, especially with what we are learning from PFIC, is variable penetrance, which means that you can have the genetic defect, but even patients or siblings having the same genetic defect don't have the same severity of illness, so don't have the same expression of the disease, which is also a complicating and confounding factor in PFIC.
Thank you. Nazreen, could you walk us through this confusing terminology of LFTs? And in the adult world, we're really doing a good job of splitting out enzymes from function. How do you explain that to patients, or do you work it all in one basket? How do you work that terminology?
Yeah, we're doing the same thing. We're really shying away from using the abbreviation LFTs because it's been misused for the enzymes, but it's actually spells liver function test. So the way I usually explain it is we spell it out that there is enzymes, which is the AST, ALT, GGT. We use way more GGT than ALK-Phos. ALK-Phos is used a lot in adults. We can't use it because it's also produced. ALK-Phos is also comes from bones, and when kids are growing, their ALK-Phos can be high. Just because there's more bone turnover, it doesn't really tell us anything about the liver. So yeah, so when I'm discussing with patients their liver tests, we separate them between liver enzymes, AST, ALT, GGT, and then you have a liver function test, which is which I don't use the abbreviation, but those tests will be the INR and bilirubin, especially the conjugated or the direct, and albumin. So that's usually how we go over, like, okay, INR is the liver function test that reflects your clotting, because liver helps with clotting. Bilirubin is that it's excreted by the liver. So if the conjugated is high, that means the liver is not excreting it. And albumin is a protein that's made in the liver. So when the liver is not working well, your albumin is going to be low.
That's really fantastic. And I wish you could train the adult hepatologist. Only about 20% of my colleagues even order GGTs, which I think is so old school that they're not even on the caboose. And also fractionating bilirubin for adult hepatologist requires, I don't know, some major, lab change before they even think about it. I, of course, check a direct in every patient if the total bilirubin is greater than 0.7. What is a healthy bilirubin? Forget Gilbert's for a moment, or Gilbert's for a moment. What is a healthy total bilirubin and direct bilirubin in a child? Maybe Amrita, you want to take that one?
Sure. So it's very similar to what it is in adults. Usually sort of total bilirubins, we like them to be less than 1. And then the direct bilirubin so the conjugated is established, but the direct varies based on labs. There's a lot of research that's being done in using conjugated bilirubin or direct bilirubin as a screening tool for liver diseases early on within the first 2 days of life. So we'll see if it ever gets implemented nationwide, then maybe we'll be able to catch these diseases much earlier.
That is incredible news. I've not heard that. That is great education. I love these, Farah. Thanks for inviting me. We get all sorts of pearls. Susan, let's go back to you and talk about managing itch in your daughters. What was there one magic medicine, or are we far along where the IBAT inhibitors like Odevixibat is working?
So both of my daughters are on a IBAT trial. Sylvie's been on it for about 2 years now, and Genevieve, my 1-year-old, got on it right at 6 months. So for Sylvie, the itching was unbearable for her. I saw it probably when she was 6 weeks old. She had another surgery before. So we had been in the hospital, but I had noticed every time that I would feed her, she would have her little IV cast on and she would use it to itch her whole face. And as you guys talked about before, it's hard to diagnose. So they gave me eczema cream. And I'm like, it's not eczema. I promise it's not eczema. It's so different. And so for her, it was a lot of itching. We did rifampin, we tried all the things. And for her, it was just a struggle until we got on that trial. And now both of them, I mean, Genevieve never even had itching at all. So it's been pretty cool.
What was the time difference between the onset of itching and when they established the liver disease diagnosis? How many weeks, months, or longer was that?
I saw Sylvie's itching starting at 6 weeks old, and then we got her diagnosis probably when she was around 6 months old. So it was a while.
I just want to give you an anecdote. I was on a patient panel last week here in San Diego with a woman who had PBC, and she presented with itching, and it took 3 years to diagnose the PBC. We were in tears. It was just such a sad story. So yeah, itching is a big flag. And yes, I go, oh, you're itching, go see a skin doctor. No, it's itching. Think about the liver. We're trying to get that message out in the primary care community, but it is going to take a while. Okay, well, that's very, very important. And I'm glad that, did you know what she's on in the IBAT trial, or is it the placebo-controlled trial?
She's not on the placebo. Yeah, we're out of the blind study now. Okay. So yeah.
And what percentage decrease in itching are you seeing now that you're open label?
I would say that in the beginning, if you would do they call it like an ItchRO score. So she was at a 5, which is the highest for sure, 5. And now she's a 0. Or if she's coming down with a cold or something, I notice her start to itch a little bit more, but pretty much a 0. There's no itching at all. So
That's amazing. I know these itching IBAT drugs are working their way into the adult population, but right now my itch patients are on 4 or 5 drugs. It'd be nice to have one and take them to a 0 instead of this salad I have to give to everybody. Let's go back to function for a minute. Nisreen, what's and also Amrita, what do you see in terms of lipid profiles, LDL, HDL, total cholesterol in these patients?
I don't think I usually see an abnormality. They're usually normal. And I actually don't even routinely check them, but we usually will check them if somebody's about to be listed for a liver transplant. They're part of the evaluation for liver transplants. And I don't think I ever had a PFIC with an abnormal cholesterol. Opposite to Alagille, where they have really high lipids and cholesterol specifically. And some of the biliary atresia patients might have high cholesterols, but not the PFICs.
Yep, same.
It was a question from one of the patients who put questions up on the post. So that was very, very helpful. In the PBC world, of course, I've seen cholesterols as high as 1,500 requiring plasmapheresis. So each disease has its own profile, absolutely. Let's see, there's a lot of people are asking questions about how do you counsel parents who have a first child about having a subsequent child. The first child has PFIC. What do you counsel? And then we can maybe circle that back to Cezanne after Nisreen and Amrita deal with that challenge.
So it is a genetic disease, which means that it's a autosomal recessive genetic disease, which means you have to have 2 gene defects in the same gene to be able to cause a defective protein. And for all of our genes, we get one from the mother and one from the father. So essentially, both parents are usually carriers. So may not have the disease, but carry one abnormal gene. If both parents are carriers, then they have a 25% chance of having a child that actually has the disease. And so essentially we'll get both defective or abnormal genes. So 25% chance of having someone with PFIC, 25% chance of having a child who does not have any of the defects, so defective genes, and then a 50% chance of being a carrier of the gene, just like the parents. Usually we say if someone has PFIC, then sometimes the family will get tested. Everyone gets to get genetic counseling, and if the family is interested in having future children, then they can definitely talk to a counselor about getting tested and sort of the path forward.
Any additional comments, Nisreen? That sound like a good outline?
Yeah, pretty much for the straightforward cases, there's always that exception. So it's always good to have the parents tested because there's sometimes new mutations. And like Amrita was mentioning, you could have the VOUS, so things can get a little complicated. It's always nice to have a geneticist on the team to help with those.
Yep. You answered my next question. That was perfect. Get a geneticist involved. And Cezanne, if you could tell us about your decision process with your 2 children when you found out having another child. You've got 3 children, as I understand, so you have one that's not affected at all. What's your comments on this whole genetic testing and education and then deciding about more children?
So definitely in our, we have a lot of social media groups that we can connect with, different families. So that is probably one of the biggest things on our forums that people talk about is, do you have another kid? And the options that go with that, in vitro, if you can test, all those different things. So for my family with Sylvie, when we found out her diagnosis, it was a relief to us because it had taken a very long time to figure out the diagnosis, and we had actually had a diagnosis that was they were just treating it as a glycogen storage disease, which I think would be a lot worse than PFIC in my brain. So I was actually relieved, but then, you know, when you soon kind of look up all the things with PFIC and everything, it kind of evened itself out. But for us and our family planning, we just, we're really big into our faith, and we prayed about it, and we didn't necessarily try for Genevieve, but when she came, I knew all the signs to look for, and Sylvie was already on the trial, so I felt a calmness about it because she's doing so well on it that I wasn't super concerned.
So your pediatric hepatology team hasn't brought transplant to the front position yet for either of your children?
No.
So this may be a gift of the drug also, right? We're hearing this data that Nazreen and Amrita were talking about, where these drugs may turn things around in the liver, even though that's not what they were developed. I mean, they were sort of developed for that. I think there were hints about that, but they went after itching first, which was much easier from a short-term perspective. It was smart for the company to do that. And do you think, are both of your children on URSO also?
Yes. Yeah. Yeah, and all of their, I would say the only thing that's elevated are their liver enzymes, but everything else is normal. Their vitamin levels, their INR, that's what initially brought both of them to the hospital to figure that out, is because their INR was high. So.
And how were they given vitamin K? Because you can take it by mouth, which is pretty worthless, or injection, right? Subcutaneous or IV. How did they replete the vitamin K?
They did an injection on both of my daughters at the hospital when we came back, not at birth. But.
And Nazreen and Amrita, how do you replace vitamin K, vitamin A, vitamin D, and E in these patients who you've got this malabsorption problem? Do they have to get it IV intermittently? If you could just run the alphabet for us, your ADEC.
Yeah, so vitamin K, as you mentioned, with problems with cholestasis and abnormal bile acid excretion, you're not going to be able to absorb fats in general, including the fat soluble vitamins. So we'll most of the time they'll end up getting it IM or IV. There is the risk of anaphylactic with it IV, but I give it IV a lot, and I think, you know, over all these years, I had one kid that might have had a little itching. It wasn't really anaphylactic. He started itching, and we're like, okay, let's switch it up. So I haven't seen the anaphylaxis. So because sometimes also when they're, you know, you can bruise. So you're gonna get a big bruise. Let's just give it through the IV so they don't get a big bruise. So yeah, so that's the route that we end up giving it. For the rest of the vitamins, they don't have we don't have parenteral forms. We just end up giving mega doses orally.
And Amrita, do you check vitamin E levels in your patients?
Yeah, we check all of them, A, E, D, and then for K, we just check the INR. But yeah, we check all of them. DECAs are not fun to give. They make the poo orange. They stain everything. So yeah, they're not great.
Right. Well, we're getting close to wrap up time here. I know we both, Dr. Sufi and Dr. Narang, looked at the questions. I think we've covered most of the things on that panel, both in the Q&A and also during your presentations. Is there any other hot topic that we need to think about? There was this issue of sleeping, but usually it's itching leading to a sleep disorder as opposed to needing sleeping aids. Anything else in there you think is important? And Farah, step in, or did we miss something important?
I had one patient who had sent information in that her PFIC was so severe that she had to wake up her mother at the middle of the night to change her sheets because she was itching so much and bleeding, and that she had to carry the feeding tube with her for her nutrition. Is that common, or is that very rare? I was just devastated when I read that for a little kid to go to school with a backpack because she had to have feeding tube, and the other kids didn't understand. They were bothering her. They just couldn't understand the disease. Have you seen a case that bad?
Yeah.
Is there any-
Yeah, unfortunately, it can be very challenging. With the liver not working right, with the bile not being there to absorb the calories from the food, just like the vitamins, where we have to give a lot of vitamins to be able to get to good levels. Same way, we have to give a lot of calories to be able to get the patients to grow. And sometimes that means getting a feeding tube in, so that way we can give feeds overnight or throughout the day, because it is a lot of volume. It's a lot of calories that sometimes may not be possible to just take by mouth. And so yes, that does happen. Usually, it is, at least in PFIC, it is something that can be slightly temporary, where you do it for the initial period, get them to grow, and things do get better with cholestasis improving. So it can be sort of a short-term thing, for sure.
There are a lot of questions on post-transplant management, but I thought, Farah, we should defer that to another presentation on pediatric liver transplantation, because there are some very complicated questions that probably relate to a variety of pediatric post-transplant issues. So I think we're at 6:45. I think this is a good
Yeah, I
time.
just have one question for Susan. How are your children weight and height side? Normal, or are they on the thin side, thin and maybe shorter?
Sylvie has grown like a weed after being on the trial, and then Genevieve is small, but it was the same as how Sylvie was when she was that age. Very big tummy. It's pretty swollen and inflamed, but her height is growing really well. So I don't think our team of doctors are super concerned with her. Sylvie had an NG tube, but that was just because she was hypoglycemic. So we were using that for both things. But yeah, they're both, they're small, but I'm a small person too. So they're kind of just looking at, and my other daughter who doesn't have PFIC was also smaller. So we're not too worried.
It's wonderful. Thank you so much, Susan. Thank you. This was a wonderful discussion. As you said, Dr. Gish, we have to come back and talk about pediatric transplantation, because I know we have wonderful doctors that do that constantly, so we need to talk with them. I want to thank you. I know it ran over time, Dr. Sufi and Dr. Narang. I know your children are probably hungry and asking for you. Thank you, Dr. Amrita Narang. Thank you, Dr. Gish. Thank you so much for your help. And Dr. Sufi, wonderful. Thank you. Thank you for your presentation. Susan, I can't thank you enough. Please stay in touch. We'd love to have you come back and talk with us. You are a wonderful mom that are living with a lot of issues. So I would really love to, you give a lot of help and guidance to the other parents who are living the same situation. And thank you to Albrio, our exclusive sponsor for tonight's program, for helping us bring information on rare pediatric diseases and raising awareness of this disease. Thank you, Albrio. So just a couple of commercial for Liver Health Foundation. We have a community-based walk coming up March 11, 2023 in Irvine. It's on the William R. Mason Park. It's a beautiful event. We will have balloons, face painting, breakfast, music. So come put your dancing shoes on and come walk with us and dance with us. You can either go to walkforyourliver.oc.org or just take a picture of this QR code and register to walk with us. Thank you. And then we are on all social media. Please visit us. We love to have your input and the material we put on our social media as well as our website. So until we see each other, hopefully March 11 at the Walk for Your Liver OC, good night and be well. Thank you.